Good afternoon. I'm going to give everybody a second to get connected. See everyone still connecting to audio and video. So good to see everybody. Happy Tuesday. So I'm Anissa Mitchell with PMD Alliance. I'm excited to have you with us in this conversation today. This is a different kind of a conversation as we are going to walk through some language used with Parkinson's, some common words that you might hear the medical community throw out that may not mean a whole lot to you. So we're going to go through some ABCs of this. Obviously, there's not the ability to go through all of the different words. So we selected a few words that we feel might be helpful for you to understand, especially as it relates to off or not being optimized with your medication. This program is a part of a series that we are doing with Amneal. So we thank our partners Amneal for this. And today we have Dr. Ramon Rodriguez, who is a movement disorder specialist from Orlando, Florida. He is the director of his practice Neurology 1 in Orlando, and he's going to be taking us through these ABCs. So I want you to open up your chat box if you would. That's where you can ask your questions as we go through some of these words. And I've already seen one shout out from Canada. Lovely to have you. Give us a shout out. Let us know where you're joining us from. And that's where you're also going to tell us where your questions are. Or what they are. And if they are an additional word than what we're going to cover, we'll try to get to those at the end. But I know that Dr. Rodriguez, quite a few words that he wants to go through. And we have Australia on here, so that's awesome. I love seeing people from all over the world join us. So Dr. Rodriguez, I'm going to go ahead and let you get launched into this because I know we have a lot to cover. So thanks for joining us today.
Oh, thank you so much for the invitation. I think that this is actually one of those programs where people will be able to gather a lot of information that I personally, as a doctor, believe will be very useful, right? Because it will help them communicate better with their doctor and understand better what is happening.
Awesome. So let's start with some A words, since we're going to go down a little bit through the alphabet. And the first word, and sometimes I feel like I don't say it right, akathisia.
That's it, akathisia.
All right, so talk to us about what this word is.
So akathisia is a symptom that might be observed in people with Parkinson's disease. And fortunately, it is not a common symptom, but I am going to give you the best description of akathisia. Just imagine that you have thousands of ants in your legs. Okay, that is the best description. So it is a sensation of restlessness. Okay, and people feel this intense urge in their body, mostly in their legs, and they will have to stand up. They have to walk around. And I know when a patient is suffering from akathisia because when I go into the room, the patient is not sitting down. And I ask them, hey, you want to go ahead and sit down so we can have a conversation? And the next thing they tell me is, well, I prefer to stand up. And every time they are there, they are a little bit restless. Sometimes they are pacing back and forth. And this is a symptom that is commonly associated with intake of some psychiatric medicines. However, sometimes the medicines that we use for the treatment of Parkinson's disease might be associated with the sensation of akathisia. So fortunately, it is rare, but for those that have akathisia, it is very nagging and very annoying.
So I have a question. Since you mentioned the feeling of maybe ants or fire on their legs, is that a different sensation than what someone might be feeling if they're having like a hallucination that's a sensory, like a feeling type of hallucination?
Yeah, so while sensory hallucinations are even more rare than akathisia, but sometimes it can be difficult to to define one versus the other and differentiate them. So I think that the closest condition that might be associated with this is restless leg syndrome, right? But restless leg typically happens at the end of the day. So it follows a circadian rhythm. And by that, what I mean is it tends to happen later in the day as nighttime is coming in. That's when restless legs will get worse. But during the day, people usually do not complain much of the problem. But if it is happening 24 hours a day, 7 days a week, then those cases are the ones that are more associated with this akathisia. But once again, it is rare to see it in Parkinson, but I've seen it every now and then.
And how is that treated?
You know what? Unfortunately, there is not much that we can do for this akathisia. Some people feel like lowering the dosage of carbidopa, levodopa might help, but obviously they will pay the price of having the symptoms of Parkinson's disease exacerbated. And then other people feel like certain medicines such as amitriptyline or gabapentin can help to mask the symptoms and decrease the symptoms to some extent. But it can be very difficult to treat. It's very nagging and very annoying.
And is there any correlation between wearing off with that, with the motor fluctuations, or if somebody has it, it's pretty static?
I think that is pretty static. That's the typical conversation and that I have with the patients. While some of them feel like there might be some times of the day where it is worse, I think that the one thing that is very particular is that, and differentiates it from restless leg, is that it is happening all day long.
Okay. So the next word is also an A word, akinesia. So can you, because I've heard this word before. I know it's been thrown out to people before. So can you describe what that is?
Yeah, so akinesia is lack of movement, okay? A person that is suffering from akinesia is having difficulty with mobility. And there's going to be another word that I'm going to go ahead and bring it right away, because there is akinesia and there is bradykinesia, right? So bradykinesia is a lesser form of akinesia. So akinesia will be more severe. So bradykinesia means slowness of movement. So everybody with Parkinson's disease has bradykinesia. It's actually, there is something that we call the UPD, or the UK Brain Bank criteria, which talks about those symptoms that are typically common and make the diagnosis of somebody with Parkinson's disease. And the bradykinesia is the one symptom that seems to be present on everybody. And bradykinesia means slowness. And we recognize this because the family notices that, daddy or mom or pop is taking a little bit longer to get ready in the morning to go to church, or he used to be the first one finishing dinner and now he is the last one. So slowness of movement. But when we talk about akinesia is now a more severe form that is associated with this lack of movement. That is the best definition. And we all know that, that's what makes Parkinson's disease very noticeable, right? That a person with Parkinson's disease has slowness or less movement, if we can say that.
So is the akinesia the same as freezing of gait?
So akinesia is not freezing of gait, okay? So while, we can say that, akinesia can be observed in the upper and the lower extremities. It doesn't have to be necessarily associated with walking, okay? So, some people, which is interesting, they call it a freezing activity, right? Because of the lack of movement, but it doesn't have to be totally paralyzed or full lack of movement, but there can be a lot of slowness in the activity, right? So freezing of gait is a different phenomenon. And, for some people, they might say this might be the akinesia when the patient is walking, right? But there are some other features of freezing of gait that makes it very, very interesting, because the freezing of gait, and we can talk about this a little bit later, there are some tricks that you might be able to break the freezing spell, right? So to me, I try to keep freezing a little bit on the outside. And akinesia is more the severe lack of movement. And I think that the best, let's think about a person that has never been medicated for Parkinson's. So they are very slow, they're very stiff, they can hardly walk. It takes a long time for them to take 10 steps. That person is said to be akinetic.
So you said if they are not medicated. So if someone's under medicated, this can be a problem. How about somebody who is just having the ups and downs of the motor fluctuations?
Yeah, so some people have such wild fluctuations from the off to the on medication state that when they're off, they're just there. They cannot move. They're paralyzed. And sometimes, what they said is, I need somebody to come and help me get out of the chair, because there's this lack of movement that they cannot even stand up, and then trying to go from one place to another, get out of the car, or go from the bathroom to the bathroom. They are very slow. So akinesia is something that is basically observed, or mostly observed, when a person is in the off medication state or the person is unmedicated. We treat a person with medicine for Parkinson because we want to move away from the akinesia.
Mm-hmm. So it's a medication treatment. Does therapy help at all with that?
Oh, yes, definitely. So when the person is taking the medicines for Parkinson's, the akinesia typically gets a lot better.
Awesome. All right. Well, you already mentioned bradykinesia. So I think you covered that. I didn't know if there was anything more you wanted to say about bradykinesia before I moved on to the next B word.
So bradykinesia is just very common to see people with Parkinson's disease. And actually, when you come to the clinic and your doctor asks you to tap your fingers or make a fist and open and close, and then you're walking from one side to the other, we're looking to the fluidity of the movement, right? And a person that is moving slower, but they're still able to do it, right? We say that person is bradykinetic, which is typical in Parkinson's. And that's what we use as a comparison to a person that is moving just normally.
Okay, so our next word is also another Brady word. So it's bradyphrenia. Bradyphrenia.
Yes,
You talk
bradyphrenia.
about that.
Yeah, so now bradyphrenia includes cognition and thinking. So let's think about it, about slowness of thinking and slowness of information processing. So I'll give you the best example. I had a patient yesterday that he was in the clinic, and every time I will ask a question, I have to be very patient because it took a long time for him to be able to bring an answer. So for example, if you ask me something, I might be able to find the answer and tell it to you right away. A person with bradyphrenia, now everything is a lot slower and it takes time. And, we as doctors have to be very mindful about that, because, we need to obtain information to help our patients, right? So I know that a patient that has bradyphrenia, then I'm going to have to be more patient to gather the information I'm looking for.
So that makes me think of when I turn on my computer and it's loading and I have to sit and wait for it. That's how the brain is working with this.
That is correct. Yes, that is correct. So everything is taking longer. And what happened is, just like we see slowness in the body, in the movement, people with Parkinson's disease, all the processes in the brain, they move slower, and it takes a little bit longer. It may take a little bit longer to retrieve some information, and the best example is, sometimes people with Parkinson's disease, they see somebody and they cannot remember their name, right? They probably went to church 3-4 years ago, and they know that person, and they're thinking about the name, or they're thinking about the name of a celebrity, who's that actress, and then you're thinking about it, and then 10 minutes later, wow, everything comes in, it's Anne Hathaway, right? Or whoever it is, and you remember who that person is. So that's when we're talking about bradyphrenia, we're talking about this slowness of thinking, where everything takes a little bit longer.
Right. And we all have that situation where we can't think of the word is, or we can't think of the name of the actor.
Mhm.
So how is this different than what a typical person might experience?
Well, so in the person with Parkinson's disease, obviously the symptoms are present all the time or most of the time, right? And you can see that there's a slowness of the speech and these ideas and what they're trying to express, it becomes slower. So it is a total phenomenon. So, a normal person might forget, like we might be having a conversation and then you can ask me something and I'm like, oh my gosh, Anis, I cannot remember this now. But you see that I'm talking normal, my speeds are normal, and everything that I'm saying is normal. But a person that is bradyphrenic, everything is slower. Doctor, I cannot remember right now what you're asking me. So, there is this connotation where the brain is moving at a lower frequency and lower speed.
And so for others that are interacting with them, care partners, family members, friends, what would you say to them? What are some tips to kind of help keep them involved in the conversation? Because that's important, because you mentioned cognition, and socialization is very much, impacting cognition. So what are some tips for people that are interacting socially with someone in this situation?
You know what? It's a matter of being patient, right? I'll tell you that, one time, I think that one of the best experiences I can tell you is I used to have a patient that he's one of the smartest people I have known. It's like he's somebody that yeah, obviously just to protect his identity, I cannot tell you a lot, but everybody has been touched by his inventions and in a great manner. And this man, he has bradyphrenia. And one time he was at an event, at a gala event, and he was talking with this other person that didn't know who he was. And obviously he's talking slower. And when the patient comes to me, he tells me, he was telling me about his frustration because they told me, they treated me like I was retarded, right? Like I couldn't communicate, like I was demented or something like that. And I am not. I'm just slower at trying to express this. So we just have to be patient because for some people with Parkinson's disease, we know that there are multiple types of Parkinson's. There's the type of Parkinson that is very shaky, but there is a type of Parkinson's that is very slow and stiff, the akinetic rigid type of Parkinson. So I feel that one person with this condition will be a little bit slower, communicating or doing the things that they want to do. So we have to be patient. We just have to wait until they are able to communicate and tell us what they feel. Okay.
And real quick, we had a question about this. They wanted to know, is it hard to differentiate bradyphrenia from beginning Lewy body dementia?
You know what? Not at all. So one of the characteristics of Lewy body dementia is that a person with Lewy body disease or Lewy body dementia will have hallucinations at the onset of their condition. They will have fluctuation in mental status as well. And they will have cognitive impairment. So I have seen some people, I have a patient right now with Lewy body dementia, but he doesn't have any bradyphrenia and he's able to move. He has a lot of cognitive issues. And, if you're able to have a conversation with him, and you probably couldn't tell that there's anything wrong with him, but as you go deeper and deeper and deeper, you begin to recognize that he's having some cognitive impairment. So the person with Lewy body disease typically has hallucinations, fluctuations in mental status, and cognitive impairment, but they might not be that bradyphrenic. They might not be as slow as other people. Some people with Parkinson's disease will be very slow as well. So.
Awesome. Okay, so we're going to move on to some D words now. This first word we're going to go through is Dysarthria. What is that?
Dysarthria is a disorder of speech. Let me see. I'm sorry about that. Disorder is a disorder of speech where the muscles that are used to produce speech might be either damaged, paralyzed, or they might be weak. So, for example, let's think about a person that had a stroke, right? So a person with a stroke has a little bit of deviation of the face, some weakness on the face. So it's difficult to understand, it's difficult to understand what they are saying, right? So you have to pay a lot of attention. So they are telling you the correct words, but it's difficult to understand because they might not be able to enunciate or put their mouth or their tongue in the correct position for them to pronunciate the words correctly. So a person with dysarthria is just difficult to understand, and you have to pay a lot more attention.
And speech therapy, that can help with this?
Yes, speech therapy is very important because what it will do is it will help strengthen those muscles that are affected. So the person is able to communicate better and will be able to provide the pronunciation of words in a manner that other people will be able to understand.
And this is seen in Parkinson's, but is this something you also see in like PSP or MSA?
That is correct. We see people with Parkinson's disease, MSA, PSP, corticobasal degeneration as well. However, going back into the D words, I'm just going to bring a new D word now, which is dysphonia, or an H word, which is hypophonia, right? So hypophonia is the most common way that that it is presented in people with Parkinson's disease, and that refers to the low volume of the speech, right? So many times when people with Parkinson's disease are trying to communicate, they might start speaking at a normal volume and speed and all that, but then as the sentence is going by, the volume of the voice comes down and it is more difficult to understand. So that will be hypophonia. So I mentioned dysphonia. Dysphonia means that there's a disorder or difficulty speaking, right, with a problem in the mouth of the vocal cord. But the way that it is manifested in people with Parkinson's disease is volume in the voice. That is the most common thing. And those are the patients that will benefit from physical therapy as well. And the one thing that I always tell my patients is you cannot wait until people cannot understand you, because it doesn't matter how much therapy you will do at that point, it is hard to go back to the normal range, right? So once a person begins to show issues with the speech, especially hypophonia, that is the best time for you to begin doing some therapy, okay? And the most important thing when we speak about therapy for people with Parkinson's disease and speech is that people need to continue practicing this at home, okay? So people go to the speech therapist, they have their sessions, everything is wonderful, everybody's noticing that they're able to speak louder, communicate better, their diction is improved. But once they go home, if they do not continue doing those exercises, then they're going to regress. They're going to go back to where they were a few months ago. So things are not going a lot better. And I'm going to tell you something. As a physician, this is one of those things that I tell people, I think it's time to go to the speech therapy. And they don't like it. No, doctor, I don't think I'm ready for that. I don't think I need it at this point. But the truth is that, it's like when you hear a sound, an unusual sound in your car, right? If you hear something run in your car, do you take it to the mechanic right away, or do you just wait to see what happens, right? So it might happen that if you don't take it right away, you let it go, now something, now a $20 fix might become a $300 fix because you didn't do it on time. So the same thing happens when we speak about speech problems in people with Parkinson's.
And you mentioned speech therapy. So Lsvt Loud is one of the ones designed to address this specifically. And it is a very intensive program, and it has shown real results. But like you said, it's important for people to continue to practice. And
that's correct.
Right.
That's correct. And I think that one of the issues with these programs is, people have to understand that this program has been tested over and over again. So they are backed up by research. and they have, this is people that tried multiple ways of doing this until they got it right. They found a way where the system is working very well. So it is very important to follow these programs right to the T, like right the way that they're meant to be. If not, they're not going to work.
And I don't want to jump ahead letters, but you mentioned hypophonia, and I want to mention hypomia. And that's another word that people probably may not have heard of before, but it's very, very common, actually. And I think the reason I asked about it is because I believe Lsvt Loud can help somewhat with that too. So I'm going to let you describe that.
Yes, so hypomia is decreased facial expression. And I'm going to tell you that this can be the first symptom, that brings somebody to the clinic. And I'll tell you that, sometimes the children bring a parent because they begin to notice, like, what, mom is not smiling as much, or she's not as expressive anymore, or that. So they typically come to the clinic because they notice that something is different. And you know what? If you Google, you go to Google and you put there, like, decrease in the facial expression or lack of expression, one of the things that is going to show up in that search is going to be Parkinson's disease, right? Or some sort of Parkinsonian syndrome. So, so this is actually, it might be one of those first symptoms that we see in people with Parkinson's disease.
And what is besides therapy, what is the other treatment options for that? Are there any?
So you know what? Let me tell you that this is actually something very interesting, okay? So when I was looking for treatment of hypomia, I went to the experts, right? And the person that I spoke with, her name is Dawn Bowers. And Dawn Bowers is a researcher at the University of Florida. And we used to work together years ago. And I asked her, hey, Dawn, yeah, that's actually her aspect, her area of research. That's one of the things that she does research in, people with Parkinson's. And I asked her, Dawn, what can I do? Because I have people that they actually complain about it and they want to know what they can do. So this sounds kind of silly, but she says this works. Okay, so number one is chewing gum. So the first recommendation, that's an easy one. Have people keep chewing gum. And we do this because this keeps the facial muscles moving in a very simple way. So that will be number one. Number two is to sing loud in the shower or wherever you may be and feel comfortable of doing it. And for how long? So that is about 15 to 20 minutes per day, okay? That is going to help with some of the pronunciation and movements in the lower face. And then the third one is actually the silliest one. So get a mirror and make exaggerated facial expression multiple times per day. And make sure that you add the upper face. So the chewing gum and the singing and whistling and all that helps with the lower face. But whenever you're doing all these silly faces, you have to include the upper face. So that is very important. Then the other intervention, just like you said, is make sure that you stay in touch with your speech therapy, because they might be able to offer other alternatives. One of them is something called respiratory strength muscle training, which is that's an intervention where they use a small device, and you actually can purchase it and take it home. It's very inexpensive, and that device can help. If you use it properly, it can help use and strengthen the weakened muscles around the mouth. It can help improve the mobility of the muscles around the mouth that are involved in facial expression. And actually, there is a website that you can find this device, which is emst150.com. And I can share that with you guys later.
I just put it up. I just put it up for them.
Perfect. So that's basically the device that we're talking about. But, the most important thing, once again, is that people need to continue practicing, right? People start, they do well. Oh my gosh, I'm doing a lot better. But then they stop. So if they stop, things will return. They're coming back.
We had a question about music therapy, like the tremble clefs. Does that help?
Yeah, so music therapy, when it comes to the facial expression, so obviously the singing component, the expression and so on, I think that that is going to have a lot of value. And then, interestingly, these things that I'm telling you are things that there has been research done looking into this, right? So we have some data that supports that these things can really help.
Okay, so let's go back. I skipped around a little bit with that question, but let's go back to some of the D words that we haven't covered yet. One that I think is very, very important is dysphagia. Can you talk about that?
Okay, so that's very important. And this is one of those things that everybody must take home today. So dysphagia refers to difficulty swallowing, okay? And this difficulty swallowing is the one thing that is associated, in the initial stages of aspiration pneumonia. So let me tell you what happens. People with Parkinson's disease can develop problems with their swallowing. And as the condition progresses, then there is always a risk that whatever they are eating or drinking, some of it might go in the wrong pipe. When it goes in the wrong pipe, it increases the risk of causing an infection in the lungs. And these type of infections are known as aspiration pneumonia. Now, the one thing that people need to understand is that aspiration pneumonia might be the #1 cause of death in people with Parkinson's disease. And typically, when a person is having symptoms of aspiration, which are basically recognized by coughing when they are eating or drinking, they are having the sensation that is making them cough. But by the time that happens, so many people are having what we call silent aspiration, which is that this was happening already before and people were not able to notice it. And for those that don't know, aspiration refers in this case to the drawing, the accidental drawing of food or fluids into the lungs, right? So when that happens, there might be some bacteria heading that way, and that is what will end up causing the pneumonia. And what happened is that after 65 years old, these things are very difficult to treat, right? Not everybody will be able to survive one of these events. Many people will require to be intubated. These are weeks of antibiotics and staying in the intensive care unit. So obviously many other things can happen during that time. So aspiration means that a person is coughing when they're eating or drinking, and that is the first sign that the patient is having dysphagia or difficulty swallowing. And at that time, you need to mention this to the doctor, because the doctor will be able to order some testing to confirm and assess the severity of the problem. And 99% of the times, the way that I do it is I refer the patient to the speech therapist, because guess what? Speech therapists also perform swallowing assessment and swallowing evaluation. So they will do a what they call a bedside swallowing assessment, just to see you swallowing and assess what is happening. Some people are having aspiration that is so bad that immediately they recognize the severity of the problem. Then after that, depending how you do, we will request a second test. And the other one is a radiologic test, where they will give you something to eat and drink, and they will have a machine that is actually able to see what you're eating or drinking and how you are swallowing that material. And then with that information, they will be able to make the best recommendations about how to decrease the chances that you will be the one person having that bad aspiration pneumonia. So the one thing to recognize is that, some people have dysphagia early in Parkinson. Some people will have it later in their condition. Either way, there is always some treatment. There is always an intervention that can be done to avoid the aspiration pneumonia. So, don't hide this from your doctor. Just make sure that you tell the doctor and they will do the full assessment.
So I have a question. Does dysphagia worsen with motor fluctuations?
That is a great question. And we're trying to answer those questions because the truth is that dysphagia will happen at any given time, okay? You can be on or you can be off. I personally believe that when you are off, you might have a little bit of a high risk of having some the exacerbation of your trouble with swallowing. But nonetheless, it can happen while you are in the on medication state. It can happen while you are in the off state.
Okay. So one more word in the D's is dystonia. And
Dystonia.
yes. So, and I know there's different types of this. So I'm going to let you go into some of that.
Yeah. So let me explain what dystonia is, and then I'll go over the most important ones that we see in people with Parkinson. So dystonia is an involuntary contraction of the muscles, right? And this involuntary contraction of the muscles might be associated with an abnormal posture, okay? So, for example, if you have a dystonia in your neck, you can have a contraction of the muscles in the neck and your head might be a little bit tilted to the side, okay? So a person might be sitting forward, but the head is a little bit tilted to the side and they're looking forward, but you see that the chin is a little bit turned to the side. However, the one thing that is complex, and I see in quite a few people with Parkinson's, is that they have dystonia, and the dystonia is very similar on both sides of the neck, right? So they don't have one side that is worse than the other side. So when that happens, if both sides are contracting in a similar way, we're not going to see a lot of the movement, but the patient is going to feel a lot of the spasms and discomfort in the neck. So it is very important that we mention this to the doctor, because while some people might take ibuprofen or a muscle relaxer and the symptoms will get better, some people will have difficult to control dystonia. And in the case of the neck, we call that cervical dystonia. And that condition can be treated with botulinum toxins. And the botulinum toxin is something that most insurance companies will be able to cover. You know, for us in the US, that is very important. We have to make sure that insurance companies will provide coverage, and that will decrease the pain and the discomfort. And one treatment may last between 3 and 4 months. So that is 3 to 4 months where that pain and discomfort in the neck is improved, is better, it's not nagging you all the time, because people with dystonia, they feel pain from morning to nighttime. And most people have one side, usually more affected than the other side, but it could happen in both sides. The other dystonia that is fairly common in people with Parkinson's is foot dystonia. And the foot dystonia can present in 2 ways. So number one is toe curling dystonia. And I have many patients that tell me, you know what, doctor, when it is 4, 5, 6 in the morning, my toes begin to curl, my symptoms get a lot worse, it is very painful, and that wakes me up from sleep, and I have to take the medicine, and sometimes I have to wait 1 hour for the medication to start working for me to be able to get moving. So the answer to that is this. So these dystonias are very commonly associated with off periods. So for example, the toe curling, you know, typically happens between 4 and 7 in the morning. And guess what? You know, maybe the last dose of the medicine was at 7, 8, or 9 p.m. the night before. So that person has a very low level of dopamine. And when the level is at the lowest, that is when the patient is going to show this toe curling. And the toe curling is very painful, right? Or, you know, the from the second to the fifth toes are going to curl, and then the big toe is going to pull back, right? And sometimes I see people that they make a hole in their sneakers to let the big toe pull up, and not rub it, because that can be quite painful. And then the other type of dystonia that we see in people with Parkinson's is what we call plantar flexion foot inversion. Now, let me tell you what that means, okay? And this is very important because people can fall as a result of this. And I see somebody saying here, writing in the chat, does the cramping of calf muscle fall into this area? And the answer is yes, it can fall into this area. There are some characteristics, but it can fall. So the person with plantar flexion foot inversion, let me go, I'm just gonna, let me see if I can write it here, so to make sure that they understand, okay? So the first one I spoke about is called toe curling dystonia, okay? Let me see, dystonia, that's one. And then the second one is plantar flexion foot inversion dystonia. There you go. Okay, so what happens in that type of dystonia is that the foot pulls down and in, okay? So when the person is walking, because the foot is down and in, the person is going, at some point, is going to trip on their toes and they're going to fall. Face forward, typically, is the way that is going to happen. And it is very important to recognize this problem because, as I mentioned for the neck, that therapy with botulinum toxins can help. The treatment with the botulinum toxins can help mitigate, minimize the intensity of the dystonia in the foot, so the person will be able to walk better and will be able to avoid falls. So many times this person will look at their shoes and they will see that one side of the shoes is already fading away, going away, because they're rubbing this area whenever they're walking. But once again, it is a reason why many people with Parkinson's disease might end up falling down. So it is very important that to address that properly right on time.
All right, somebody was wanting to know, what is the toxin? It's
okay, what is the toxin? There you go.
The
yes.
botulism toxin.
Okay, so it's botulinum toxins. So there are. I'm just going to mention, in the United States we have 4 different brands. Okay, well, there might be even more, but from the medical perspective, as a neurologist, there's Botox. There is something called Xeamine. There is something called Dysport, and there is something called Myoblock. Okay, so that therapy with the botulinum toxins might be helpful. And then other countries might have access to other toxins as well. It depends whatever is available in each country. But these are treatments that are typically done every 3 months, and the benefit lasts that long. So it's one day, where for 10 to 15 minutes you will have multiple injections, and it will hurt, it will be painful. But then after that, things are going to get better, right? You will have 3 months, or you will have some benefits. So it is worth it.
All right, and I'm going to throw out one more word related to the cervical dystonia, and that's torticollis. Yeah,
so torticollis is just, what it means. So listen, we speak about torticollis in babies that have the deviation of the head. So torticollis basically refers to the deviation of the chin, right? So right now I have torticollis to the right. Here I have torticollis to the left, right? So torticollis means to that muscle contraction and the deviation, and typically those conditions can be associated with pain. As a doctor, we like to call it, in this particular case of people with Parkinson's, we call it cervical dystonia. And we do it that way because in order for us to get the medicine that you need, that's what the insurance companies and the medical system, that's the terminology that we use in order to cover this, okay?
And one real quick question about the dystonia. They want to know, what is it called when the foot goes out rather than inward?
It is still a dystonia. So the one that I mentioned is the one that I see 9 out of 10 times, okay? So is the plantar flexion foot inversion is something that is just very common. 9 out of 10 cases will come that way, but it can come multiple ways. And some people will have plantar flexion and toe curling. Some people feel like the calves might be contracting as well, and the toes will curl. Some people feel like the foot is just turning in and nothing else. So everybody, it might present a little bit different, but if I think about all the patients that I see in my clinic, I have to say that 9 out of 10 will come with the classic plantar flexion foot inversion.
Awesome. Okay, so now we're going to move on to an E word, executive function. We hear this a lot. So can you explain that?
Yeah, so when we speak about executive function, now we're thinking about our thinking, okay? And executive function refers to the processes in the brain that will help you handle information, right? And it will help you organize how your brain is working properly, right? So let me tell you what I'm going to give you an example, because people with Parkinson's disease are frequently affected by problems with executive function, right? So when we think about this, we're talking about that part of the brain that help us with planning. It will help us with focusing our attention. It will help us with remembering instructions, okay? And the most important thing is that it will help us with juggling multiple things at the same time. So a person with Parkinson's disease and typically people with Parkinson's disease might have some problems with executive function. The first thing that they begin to notice is that they are not able to multitask the same way. So instead of being able to do 3, 4, 5 things at the same time, like many people actually do, I don't know how they do. I'm not a good multitasker, I have to say, but many people is able to do this and they do it very well. But somebody with Parkinson's disease will begin to notice that they will not be able to do this as well. So always my recommendation to people with Parkinson's disease, I want you to do one thing at a time. And many times people with Parkinson's, they come to the clinic complaining that they have been more forgetful. They forget to do things, or the spouse told them to do something and they forgot about it. And many times what happens is that, you know, the patient is balancing the checkbook, and then the spouse comes and tell them, hey, by the way, make sure that you call your sister about, you know, this or that situation, right? But the patient is doing something. So the person might not get that full memory. You know, there's not a lot of attention and focusing on whatever they were said. So they're going to forget right away. It's come from one ear and it's leaving by the other one, and they did not consolidate that memory. So so the person will look like they're forgetting about things easy, but it's not that they're having Alzheimer's or anything like that. It's just that they just didn't grasp that memory in the right place because they were just not paying their full attention into it. So executive function is very common in people with Parkinson's. Sometimes it's hard to find the right word. And you know what, a little bit earlier, you were talking about when you are in the computer trying to do something, right? So I always compare this executive function as a slow computer, or a laptop from 10 years ago, right? So what would happen is, as you're trying to do something, you see that the clock is just going around and around and around, but you know that if you let it long enough, it's going to happen, right? You say, I'll go get a drink. When I get back, this is going to be ready. So the same thing happens to people. So the activity typically happens. It's just that you cannot juggle too many things at a time.
Don't have too many tabs open on your computer, if we're going to keep that analogy.
Yeah, that's what it is. That's what it is. Yes.
Okay. So I have an F word for you, festination.
Yes, festination. That is a very important word for people with Parkinson's disease to know. So festination means that involuntary acceleration of gait. And let me tell you how that looks. So a person with Parkinson's, sometimes they begin to walk and they feel like the upper body is just leaning forward and the legs are just trying to catch up, and they're just walking faster and faster and faster. And the truth is that if they are not able to hold on to something or to a wall or something like that, they actually might end up falling down. And this can be an issue even in people that use a walker. because if the walker doesn't have a brake, they will just continue moving forward and shuffling forward. And as time goes by, they are just moving faster and faster and faster. And the issue is that if they are not able to stop themselves, they are going to fall down, and they're going to fall face down. So this is one of those other conditions where going to physical therapy is going to be very helpful, okay? Because when you go to the physical therapies, they're going to teach you multiple things, and one of them is how to stop yourself when this problem is happening, okay? And all you have to do is just practice that position. That is why, there are multiple therapies that we do with people with Parkinson's. One of the therapies that I find very useful is the boxing therapy, right? Because they are always practicing their balance, the position of their feet, and so on, so that they learn immediately how to hold their balance if this is a problem that is happening. So the other word, the opposite to fascination, which is when your body's just accelerating and going forward, the other word that we need to understand is retropulsion, right? And retropulsion is a relatively similar problem, but now we're talking about going backwards. So every time we talk about fascination, we are moving forward. When we talk about retropulsion, now the patient is moving backwards. So for example, the person is intending to take a step back or two, but they just continue going back, and they're just trying to catch themselves. And unfortunately, if nobody comes and helps them and holds them, they're going to fall down, and they're going to fall down backwards, right? So this is the complete opposite of fascination in people with Parkinson's disease or Parkinsonian syndrome. This can be seen in MSA. This can be seen in PSP. This can be seen in CBD. And I'm going to tell you something. Everything, all these words that we have mentioned here apply not only for Parkinson's, but for all the Parkinsonian syndromes, because every single thing that we have discussed today happens in people with Parkinson's plus or secondary Parkinsonism. That is why it is so difficult to differentiate one condition from the other, right? And you have to wait a little bit longer for you to understand very well as a doctor how the condition is behaving in the patient for you to be able to make that final diagnosis. But all those conditions come with these symptoms and all these words that we're talking about in one way or another. That's what makes many times the diagnosis of Parkinson's disease something complex.
And does the fascination or retropulsion respond to medications? Is that help at all, or is it really just therapy?
No, medication is important in these cases. And I'll tell you that I do have patients that when they are in the off medication state, they suffer from fascination and retropulsion, but whenever they are on, they look almost normal, or they feel much better, and they do not have the problem. And actually, I'll give an example. In our clinic, we do DBS therapy. And one of the things that we do is we see people in the off state. We ask them to come in the off medication state for at least 12 hours. And then we examine them at that time. And many times we see the fascination, the retropulsion, and some of the symptoms. They may have some dystonic phenomenon as well. And then we give them the medicine and we reassess. And it's impressive how you see all those symptoms to get better, right? So in those patients in particular, doing DBS or doing one of these other therapies, long infusions of levodopa, intestinal infusions, and so on, it is very important because it will help avoid all these complications of Parkinson's.
And a question came in about this. Does walking with a metronome help with those?
So you know what? Walking with a metronome, some people with freezing of gait and difficulty walking feel like it can help. The answer is yes. Some people have found that to be helpful.
Okay. So I'm going to move on. We have an O word, orthostatic hypotension. or we can add neurogenic to that. So maybe you can explain what that is and what maybe the differences between the two.
Yeah, so I'll be happy to explain that. And this is, once again, this is very important for everybody involved in the care of people with Parkinson's. So orthostatic hypotension refers to a drop in blood pressure, okay? And that's the simplest way to do it. So, there's a definition, it is a drop in 20 millimeters of mercury in the systolic, or 10 millimeters of mercury in the diastolic. And the end result is this. A person with orthostatic hypotension, I'm going to tell you how they look. This is a person that whenever they change position, so they're going from the lying down or sitting position to standing up, within the next 5 minutes, they might have the sensation that they are feeling dizzy, or they might feel that they have the sensation that they're going to faint, or in fact, they faint, okay? And they will lose consciousness and pass out. And what happens is that in people with Parkinson's, we have a part of our brain, of our body, of our nervous system, that is called the autonomic nervous system, that is in charge of controlling pressures and avoid these kind of problems, okay? What happens in people with Parkinson's and Parkinson's plus syndrome, even worse in people with MSA, they're very well known for having this problem, is that mechanism, that compensatory mechanism to avoid this is not working properly. And because it is the autonomic nervous system what is not working properly, that is why we call it neurogenic orthostatic hypotension. And because the nervous system is the one that is not working properly or sending the correct signal. So what is going to happen is that people with neurogenic orthostatic hypotension or orthostatic hypotension, when they stand up, they feel dizzy, they feel the sensation that they might faint. Sometimes they have shoulder pain or some other symptoms. And other patients have a sensation of cloudiness in the head, like there's a cloud after I stand up for the next 5 minutes. So it is so important that after standing up, you keep track of the symptoms and you make sure that the patient is not going to pass out. And the issue is that once they pass out and they're lying flat, now there is good flow of the blood to the brain again, and the patient will wake up and feel back to normal, okay? This is very important to recognize because there is treatment for this as well. And the easiest treatment for this, guess what, is drinking water. Okay, so the person with orthostatic hypotension needs to drink more water. They actually can have more sodium in the diet, okay? And they have to wear the compressive socks. So you see that now we're doing three things: drink more water, more sodium in the diet, compressive socks. So we haven't had to add a medicine yet, right? So we can do some things to do that. The problem is that many people, many patients tell me, doctor, I don't want to drink more water. I don't want to be going to the bathroom all the time. I'm okay with adding more salt to the diet. Everybody loves that one. And then in a place like Florida, people don't like to use the compressive socks, right? Because it's always, it's hot in here. So for those people that they don't find any benefit, then they will go ahead and we can start using some medicines that will help keep the blood pressure up.
And I had a question. Can this happen when sitting after a meal?
So you know what? That phenomenon that happens sitting after a meal that is similar to this, I am going to type it because it's give me 1 second. There you go. Hypertension. There you go. So yeah. So when people are sitting down and they're having a meal, especially a large meal, and they start feeling dizzy, right? Or some people even pass out. Some people pass out. It's called postprandial hypotension. And the phenomenon is fairly similar. So what happens is that after eating, there's a lot of blood that goes into the intestinal system to work with digestion, right? And that is at the expense of blood in the periphery. So people suffering from postprandial hypotension, they actually might feel that they might feel dizzy, or they might even pass out. I see a patient every now and then that they're having this problem. So I usually tell them to have small, frequent meals right? And then, they're typically able to tolerate this better. And then, we see a comment after sitting on the toilet too. Yeah, especially, when you're pushing in the toilet or you know what, in men with enlarged prostates, they have to push to be able to urinate. So there is something called a Valsalva maneuver that happens during that time, and that can cause a drop in the blood pressure, and people might end up passing out. So I've seen this a few times at the airport. You go to the bathroom at the airport and somebody passes out. Typically somebody, that has a history of enlarged prostate. They have been traveling, they didn't take their medicines, and they were pushing to bring it out, and they pass out because they did a difficult push or a Valsalva maneuver. That's what happens, and causes this problem.
And water and sodium helps both orthostatic hypotension and neurogenic orthostatic hypotension.
That is correct. Yeah. So orthostatic hypotension is the general term, right? So listen, if you do not drink water for a long time, you will have orthostatic hypotension because of dehydration, right? So it's not, that case is not neurogenic. Or you know what? Some people, they forgot they took the blood pressure pill, so they took a second dose, and now they are over medicated, so the blood pressure goes down, right? So in that case, it's not neurogenic. It's because they took too much blood pressure medicine, and the blood pressure is going down too much, and they will have similar symptoms. So neurogenic means that there's a part of the nervous system that is not working properly.
So I know we're running out of time, but do you have time for a couple more words?
Sure, go ahead.
All right. So one that we hear a lot is the word prodromal.
Oh, prodromal means, prodromal is a term used for the early signs of a condition that still are not sufficient to make a diagnosis, okay? So let me give you an example in Parkinson's, okay? So, as doctors, we believe that if a person has decrease in the sense of smell, constipation, and something called REM behavior disorder, which is the acting out the dreams, we believe that and constipation. So those are prodromal symptoms of Parkinson's disease, symptoms that happens before the diagnosis is made, and you really cannot make a diagnosis of Parkinson's based on that. However, those are the symptoms that tends to happen before the majority of the symptoms occur that allows you as a doctor to make a diagnosis. So, at that point is when you see the doctor. I'll give you an example. So in my clinic, a person comes with tremors, and that is the symptom that is bringing them to the clinic. So I typically ask them, have you had decreased sense of smell? Have you had vivid dreams? Have you had problems with constipation? So whenever, and they say yes, yes, yes. So those are the prodromal symptoms of Parkinson's disease, and eventually can make a diagnosis.
All right, I got two more words. I'm going to pair them because they sound similar. Rhinorrhea, sialorrhea.
All righty. Okay. So,
and they're both running, sort of.
Yes. So rhinorrhea is a runny nose. And I have to say that 35 to 50% of people with Parkinson's disease can have a runny nose that is not because of an allergy. It's not sinusitis. It's not that they are sick. It's not that they're having a cold. And to be honest, we don't know why that happens. There is the belief that there is a lack of nerve connections to some cells in the nasal or in the nasopharyngeal mucosa, and that is associated with this rhinorrhea. So that's the idea behind it. That's the theory, but we really do not know why this is happening. But nonetheless, it happens in 35 to 50% of people with Parkinson's. I usually tell them to take some Benadryl or something just in case that there might be an element of allergies, right? Or just a medicine that they will be able to tolerate. They always have to talk that with their doctors. Now, sialorrhea is drooling, and drooling is the excessive production of saliva. And interestingly, in people with Parkinson's, we see what we call anterior drooling, which is when the saliva is going out of your mouth, right? So it's very embarrassing. Many people become socially isolated because they are drooling all the time, right? And there's actually a posterior drooling, and many people are not aware of this, right? But I'm gonna tell you, I have to tell you that a lot of the people, some people with Parkinson's, when they wake up in the morning, they feel like there is a mucus plug right in the back of their mouth, right? Like they say, doctor, I have like a bunch of saliva just stuck there. So what happens there is that there's just a lot of salivas and that just accumulated there during the night, and it becomes like a mucus plug. And then in the morning, they just cough and cough until they finally bring it out. So that is an element of sialorrhea. Now, people having issues with drooling in Parkinson's disease, they have a treatment for that, right? And the treatment for that is typically injections. We talked earlier about botulinum toxins. We use those for people with drooling in Parkinson's disease. And we like the botulinum toxins because the typical oral medicines that are used to control drooling in a person with Parkinson's might induce hallucinations, confusion, memory problems, and increased falls. So that is why we prefer to not use the typical medications that we use for other people, like that have drooling or sialorrhea and children. So we don't, we try to avoid those medicines, right? So that's the difference. So rhinorrhea is the runny nose. Sialorrhea is the drooling. Now I see a comment here, and I made a comment. I heard that Benadryl is a big no. So listen, just like every medicine, right? So some people will have side effects of a medicine like Benadryl. Some people might find it to be useful, actually. So that's what I say. Benadryl might be an option. Always talk to your doctor whether that might be a medicine for you, okay? And then there's another comment. I often hear a prescription eye drop that is used for this condition, and the answer is you are correct. So we use atropine eye drops, and we have the person put a little bit of the eye drops in their mouth. And once again, I'm not telling you go ahead and find some atropine drops and do this. You always have to call, discuss this with your doctor, because still the eye drops might cause the confusion and the hallucination. So yes, they are an option. You just have to make sure that your patient or your caregiver, or your loved one will be able to tolerate that medicine, and that is why you have this conversation. Now, what about an injection of alcohol for the sialorrhea? I haven't done that. I'm not aware of people doing the alcohol injection for the sialorrhea or the drooling. There's a lot of treatments, denervation of the salivary glands, and there can be photocoagulation or radiation treatment. Yeah, so I see here that is being used in children. Yeah. Yes, in adults, I have not seen this as a popular way of doing this. I am going to tell you that the botulinum toxin injections, which adults are typically able to sit down and just lay still for the injection, typically works very well, and the benefit lasts between 3 and 4 months. Insurance covers the treatment, and it's relatively easy. So I think that the botulinum toxin might be a better alternative.
Awesome. Well, I want to thank you for going through some of these many, many words that are out there and explaining them and breaking it down for us. If you registered before this morning, you would have received a confirmation email that had a handout, which is actually a glossary of terms. And if you didn't receive it yet, you're going to get an email after the program today, and those will be available. These words will be on there in addition to many, many others. And as Dr. Rodriguez said, this was chapter 1. So we may have to go through some other words in the future, but I think it's very helpful to have these conversations so we can understand what these terms that we hear frequently actually mean and how do they impact you in your life. So Dr. Rodriguez, thank you so very much for breaking this down and being a part of this program today.
Oh, well, thank you for the invitation. I always enjoy having a chance to speak with patients and their care partners. And I love when they go to the chat and they put their questions or their comment. And, you know, like somebody put there, the banner is a big no. I love it because obviously, you know, it provides that opportunity to discuss like, oh, it's not that much of a no. Some people might be fine. Other people will be a big no. So listen, it is very important. We love hearing the comments. We love your questions because that makes the program much better. So I really appreciate everybody that joined today. I hope we can do this again. And there are many other words that we can discuss. So I hope we can do this again.
Absolutely. And I want to give everybody a chance to save their chat because there were some resources in there, plus all of the words were written out as we were going through them. So if you don't know how to save your chat, if you go to where you actually write your chat, and go over to the far right, there's 3 little buttons and you click on that, it says more, and that will allow you to save the chat so you can keep all of that information and give you a second to do that. In the meantime, I want to thank Amneal for being a part of this program and sponsoring it. And I want to thank all of you for joining us. So I would love it if we could all give the wave of thanks and gratitude to Dr. Rodriguez and to each other, and hope that you guys all have a good rest of your Tuesday.
Alrighty, bye-bye.
Bye. Thank you so much.
Bye.